Good morning and warm welcome on behalf of the World Heart Federation to this beautiful day. As we all know, CVD, cardiovascular disease, remains the first cause of death worldwide, despite effective and available treatment. One of the big challenges we're facing, as we all know, is adherence to treatment or non-adherence to prescribed treatments. And the impact is huge. It leads to poor health outcome, increased healthcare costs, productivity losses, and on the basics, it's a huge equity issue. In 2003, WHO highlighted the global barrier that poor adherence poses to the treatment of chronic disease such as cardiovascular disease, HIV, and depression. And 20 years later, this challenge persists, depriving health system of the benefits that could have been realized at no additional cost. Some recent work by the Economic Cooperation and Development has shown that emphasize the lack of support for patients and prescribed medications. Many never fill their prescription, and those who do, the majority discontinue the treatment within the first year. This represents, of course, a significant missed opportunity, not only to improve patient outcomes, but also to enhance equity in healthcare system. The aim of this event is twofold. The first one is to raise awareness on the critical role of therapeutic adherence in reducing the burden of cardiovascular disease, and more important, to highlight innovative approaches and best practice for enhancing patient adherence to prescribed medication and lifestyle intervention for cardiovascular disease. I wish to welcome Dr. Rita Sada Machado from Portugal. Thank you for joining us today. And Dr. Taskin Khan from WHO. It's very busy days for you, both of us. Thank you for joining us today. I also wish to express our thanks to Servier for their support in helping us to make this event. And now it's my pleasure to introduce the first chair of our panel, Professor Claudio Borghi.
Thank you very much, Professor Ezele, and thank you to everybody. It's a great pleasure and a great honor for me to be here today to this meeting, which is focused on, I think, probably the most important topic in cardiovascular treatment and cardiovascular prevention. Professor Ezele has already summarized the problem of adherence, and the problem of adherence applies to the main non-communicable diseases like hypertension, like lipid disorder, like diabetes, which means a lot of people who doesn't take the drug and a lot of people who die because of they don't take the drug, and at the same time a lot of money which is wasted by the system try to support a good treatment of these very important diseases. Of course, the approach to adherence have many differences. One is from the patient point of view, the other one is from the health system point of view. And I think in this first part of the meeting, we try to address which one are the way to identify and to try to propose some solution for the problem of adherence, not based just on a small number of countries or just on our continent, on Europe, but we try to, let's say, enlarge our point of view by including the world. And that is the reason why I think we are here in Geneva, which is such an iconic place for the health system worldwide. So basically, I think it's time to start, and we have about half an hour for this first part of the meeting. And we have a number of speakers that allowed about 5 minutes, I think, for each speaker. So I would like to try to check if the control of the time, since we have a second part. And after that, I think we have some Q and answer discussion that could be, I think, pretty interesting for everybody. So now is time to start, and it's a great pleasure for me to call to the podium Dr. Rita Sada Machado, which is Director General of Health in Portugal. And first of all, And the question is very simple. What do you mean when you think about adherence, and what is the way that you are imagining adherence can be managed and solved in a very important country like Portugal, where the health system is very well organized, and I know there is a lot of initiative just to support not just adherence, but adherence is probably one of the most important point and one of the most important target of the health system. Please.
Thank you. Good morning to everyone, and thank you so much for this invitation. It's a pleasure for us to share the experience also of Portugal and to talk about our challenges and also what we try to do to overcome these challenges. First of all, we already know the burden and how important cardiovascular disease as the leading cause of death in Europe, and also the burden that leads into our health systems. But in Portugal alone, the cardiovascular diseases claimed more or less 32,996 deaths just in 2022. And this for almost 11 million people, it's a quite significant number. It's still the leading cause. So for us, when we look at the poor adherence to treatment in individuals with chronic illnesses, particular cardiometabolic diseases, we look at the long-term care. So we look on prevention. We look also a little bit on health promotion. I'm going to speak why is that. And of course, we also look at specifically what we have been implementing there. So this non-adherence significantly impacts, of course, the health outcomes and the quality of life, and leads to the increased healthcare costs that we already discussed. And for Portugal, this is no exception. To tackle this issue effectively, we understood that it was crucial to understand its determinants. So the poor treatment adherence stems these multifaceted causes, including socioeconomic factors, the patient-related issue, disease-specific conditions or treatment-related factors, and of course the healthcare system's limitation. Although we know we have good performance indicators for health systems, we have still a lot to improve, and we are still also facing a healthcare reform currently, and I'm going to speak a little bit about it. I promise I won't speak very much or a lot on that to get the time. So one of the things that is important is, of course, we know that sometimes patients often try to offset the high cost of prescription drugs by reducing their dosages or purchasing medications abroad, highlighting this critical role that the cost plays in adherence. Additional, of course, education and literacy levels significantly influence treatment adherence. So let me give you now the few examples from my country. So firstly, Portugal has been investing in health literacy to overcome many of the health challenges we face. So for over a decade, health literacy has empowered individuals with the cognitive and social skills needed to access, comprehend, evaluate, and apply health information, promoting and maintaining good health and well-being. And we have a health literacy strategy, our first one. But however, we understood that that specific health literacy strategy was not enough. And why was that? Because we understood that it was also important to incorporate behavioral sciences to enhance motivation and create environments that support the adoption and maintaining of healthy behaviors, including adherence to treatments and lifestyle interventions for disease management. So to this end, we have a new strategy and its action plan, of course, that we have developed a new health literacy and behavioral science action plan. And this integrated approach aims to coordinate various responses in disease prevention, health protection, promotion, and also some disease management. So it aligns with the efforts to address health determinants, particularly lifestyle factors, considering the diverse stages of life and the challenges of navigating the health systems. Portugal is very committed to implementing local actions and long-term sustainable projects, engaging community partners, and enhancing the role of social micro-influencers. And these have been very good for us, and it was a strategy with, I would say, impact on the health outcomes. Secondly, Portugal has invested in creating team-based care involving physicians, pharmacists, nurses, psychologists, social workers, and other health professionals to educate patients and monitor adherence. This initiative is part of the new healthcare architecture that brings primary healthcare, hospitals, and public health closer together. So we are reorganizing the system to make these three areas to work more in line. At the community level, we are promoting the role of primary healthcare teams and pharmacists. So, for example, we have a new program that allows the dispensing of specific medications close to the patients, improving access and preventing missing doses. Pharmacists are also able to clarify medication regimes, review side effects, and provide patient counseling, significantly reducing adverse drug effects and, of course, non-adherence. So this is one of our main goals. Thirdly, we also must address, and we are doing that, our lifestyle risk factors. And studies have showed us that these unhealthy lifestyles are associated with poor adherence to medication for chronic conditions. So for patients, for example, with cardiometabolic diseases, comprehensive risk factor management through lifestyle modification, and we are talking about smoking cessation, weight control, and physical activity, and evidence-based medical therapies are essential for improving survival and preventing recurrent cardiovascular events. Smoking, for instance, negatively impacts medication adherence, so we are also tackling this issue. Therefore, addressing smoking cessation and promoting physical activity and healthy diets are crucial. So we are also leveraging, for example, on the physical activity part, we are using digital tools for brief assessments and counseling, and we launched a national-wide campaign that is called Follow the Whistle. And this is a campaign that will continue this year and tries to promote physical activity no matter what. If you go, through the stairs, if you just walk your dog, so to try and improve this for patients. Regarding healthy eating, and this is my last part, Portugal has implemented policies to reduce salt intake by getting legal limits for salt content in bread, for example. And this is a huge part, who knows our magnificent, I will say, food culture, but we eat a lot of bread. So for us, it was very important to have this legal limit of salt intakes in bread, and engaging also in food reformulation plan with the food industry to reduce salt in various products. So between 2018 and also 2021, this plan achieved an 11% reduction in average salt content across different food categories. So this was very impactful so far, but we want to do more, of course. So in conclusion, improving treatment adherence for cardiometabolic diseases is challenging, of course, this too multifactorial nature. But we have strategies to enhance adherence, and these strategies must be multidimensional. So we are not looking only on the health literacy part, we are also looking at how the health system is organized, and of course we are looking also on the lifestyle factors, because we know that these patients will have more probability not adhering to the treatment, as they do not adhere also to the lifestyle that they know that they should, of course, react to. So together, I understand that we can significantly impact patients' quality of life, public health outcomes, and the sustainability of the healthcare system across Europe and also globally. So thank you so much.
Thank you very much. Thank you very much for your excellent presentation and for keeping exactly on time. Stay there. All the panelists will stay on their chair so we can have a final discussion. So do you think that the system that you apply to Portugal, I know that Portugal is a wonderful place and the people is pretty much committed, could be exported to many other countries? So do you believe that you should be as Portugal to see this system works?
What we have seen in specific forums is that these examples are examples that could be taken elsewhere. Of course, sometimes they are culture-based, but there are a lot of things related to policies or even for health system organization that can be taken elsewhere. And of course, we have been, showcasing through WHO, through other partners, and it's important to continue the conversation with, all over the world, I believe.
Thank you. Now I think it's time to move on to probably our host. And it's a great pleasure for me to introduce Dr. Taskin Khan. Dr. Taskin Khan is currently is a medical officer responsible for cardiovascular disease program implementation in the non-communicable disease management unit at the World Health Organization headquarters here in Geneva. I think this is a very important part of the organization because most of the non-adherence to treatment is definitely related to the non-communicable disease and all those situations where you have to take the drug just imagining that the adherence would have some benefit in the next future. So I think your point of view is very important, and I'm looking forward to listen to your idea about how to solve and how to manage this very important problem of adherence to treatment. Please.
Thank you so much. A pleasure to be here, everyone, to talk about something, yes, that's a bit of a challenge and a sort of obstacle that we've seen even in programs running on hypertension, on diabetes, but quite a few challenges, as you said, I think earlier. The patient perspective, the health system perspective, etc. But to me, I'll give you a story to crystallize the truth about adherence. I used to work in a primary care clinic in Cape Town when I initially completed my internship and community service. And one day, a patient's daughter came to me, and she said she had something for me. Her father had passed away. He was a chronic patient, everything, hypertension, diabetes, lipid treatment, secondary prevention. So he had a host of chronic conditions. And she brought to the office a massive plastic bag. It was like Santa's sack. It was of all the medications that they had been collecting from our clinic, but that her father never ever took. And it was, I looked at it and I went, seriously? Like, you had like all of this? And she said, yes, we also didn't know. He had been collecting the meds, coming to see the doctor regularly, taking it the week before his checkup, and then never taking it again. And that, for me, really showed what exactly was happening behind doors. Because it meant that he probably passed away from an event. No doubt, he was elderly, but there was no reason for it, most likely. It was because he wasn't adhering to his treatment. But it also made a few other things come to mind, that the family members are also so important in the chain. I have another story. I was leaving my post and a patient came to see me and she was crying. She was in tears. And I thought, oh gosh, now what did I do, And I asked her what was the problem. And she told me that she was extremely sad that I was leaving because I was the only person who explained to her that if she didn't take her hypertension meds, she would go on to have a stroke or a heart attack. That in all her years of receiving chronic therapy, nobody told her what would happen if she didn't take her medicines. And now that I was leaving, she wasn't sure that she'd have that policing person to actually check and make sure, that she was on her treatment. So that's a patient factor. And it lends itself to the fact that we're not very good at explaining the consequences in chronic diseases. I think in non-communicable diseases, and there's quite a few examples there about adherence to treatment as well, whether you look at tuberculosis or HIV, which are now both chronic conditions, you see that their patients are a bit more educated. They've spent a long time on health literacy, but also on provider literacy and the ability to get the message out. They've got social support systems, which I think we do have some examples in the NCD adherence clubs and things which are trying to get off the mark. But the thing is, you also have fear. And fear is a big driver, I think, for adherence. When you see people dying of opportunistic infections, and it's not at all a pretty sight, you do definitely have the will, I think, to take a medication. With diseases that are chronic, they're generally silent. Yeah. And unfortunately, that's why we call hypertension the silent killer, but the patients are also silent. And it's a funny mix, I think, and especially in cardiovascular diseases, actually. It's not just hypertension. A lot of patients, even receiving secondary prevention therapy, are very quiet about their illness. They see it, as a fact of life, and they kind of go on with it. But we've been seeing dropout rates of as high as 70%. And the thing is, we've got to go back and try and think. So in TB, you had DOTS, directly observed treatment, where you had healthcare workers that went out and actually observed patients taking the Rifafo. I know it's a pie in the sky idea to think that that's what's going to happen for chronic diseases, but I do think that there are now more novel approaches that can be thought of, and there are things like community health workers, community health aides, even local support in the form of champions that can encourage people not only to adhere to treatment, but also explain to them the consequences of what exactly it means not to take treatment. And I think that's a huge element that we need to get into: patient education, provider education, and health literacy.
So thank you very much for your contribution. I think you have touched some very important problems, and in particular the problem of trying to explain the patient which one could be the consequences of non-adherence, because I think not only hypertension, but most of the non-communicable disease are absolutely silent. Besides hypertension, you think about lipid disorders. So there is no specific symptoms for lipid disorders unless you have a complication. So you have to be educated to do that. And I think you touch another very important point, the point of family members. All the people around the patient should take care of supporting the correct use of drugs to try to contribute to the overall adherence to treatment. And I think it's something like a network which resembles to the idea of coalition, and the coalition is the word which is behind this activity we are doing now, and we did in Brussels a couple of months ago, a coalition of different forces that are moving in the same direction, trying to improve the adherence, and through the adherence, trying to improve the clinical outcome and to spare money, which I think is something that we don't have to forget. We are paying a lot of money without getting back any results in terms of cardiovascular prevention. So let's move now outside the area of Europe, of world, and getting in more specific realities. And it's a great honor for me to call to the podium Professor Elia Ogola. Professor Ogola is Vice President of East Pan-African Society of Cardiology and Chairman of the Department of Clinical Medicine at the University of Nairobi in Kenya. He's a clinical cardiologist, but of course he has a lot of interest in the research, and as all of us, he has a lot of interest in adherence and in trying to support this coalition for adherence. So, Professor Ogola, the podium is yours.
Thank you very much for having me. It's a little difficult coming after these two very eloquent ladies. I must say that that information is a little outdated. It was when I was still vice president of the Pan-African Society of Cardiology. I've actually been president for the last 2 years now. So I've gone up a little in the hierarchy. Yeah, the question of adherence is, of course, an important thing. And generically, of course, the issues are common across, the world. But when you deal with a situation like what we have in Africa, then, of course, there are specificities in terms of the manifestation that probably require more targeted, more innovative approaches. Like has been said, there are patient-related factors, there are health system-related factors, and broadly societal factors. And when you're dealing in an environment of resource constraints like we have in Africa, then these extra patient-related factors become relatively more significant. So there is, of course, the issue of all of us know that, adherence is directly related to the complexity of treatment. So I'll start with that because it is a simple one. Is that for the first time, wearing my hat now as a Kenyan, not as president of the Pan-African Society of Cardiology, in our latest recommendations for the essential medicines list, we finally convinced the Ministry of Health to include fixed dose combinations for antihypertensive therapy in our essential medicines list. The consequence of that is then that it is easier for the public health care system. We have a parallel sort of healthcare system in Kenya. It's public, there's private. Is able to procure the fixed dose combinations, and with the economies of scale with the bulk procurement that makes it cheaper. But then, like I said, in our environment, then those other factors become important. As an example, to show the significance of these factors, one of the research institutions in Nairobi did actually a randomized clinical trial in a slum area in Nairobi, where in one arm, they actually gave the patient support, gave the drugs free and all that, and compared with, if you like, usual care. And there was absolutely no difference in adherence, absolutely no difference. And this really illustrates these other factors because this is an informal settlement. Many of these guys are doing informal work. Their earnings are on a daily basis. If they miss work for one day, they have no food for that day. And the structure of the healthcare system is such that because of crowding, because of lack of healthcare personnel and all that, going to the clinic means committing the whole of that day. So that's a whole day's earning. So the essence of this brief story is to say that if we are going to tackle adherence, things like fixed dose combinations, of which I'm a very passionate advocate of, as some of you here know, we really need to go beyond that to the organization of the healthcare system, including things like the frequency with which you have to refill your drugs. In many places in our world, you probably have to refill your drugs every 2 weeks, because if I give you 3 months, then I can't give everybody. So all these issues are important. And then, of course, the broader societal issues like education, the extent of healthcare financing, and all that. So clearly, adherence is an important issue. It is a multifactorial issue. As for many things in health, the solutions go beyond the immediate health environment. We can be advocates for that, but we have to work with a broader society. And I think those are my brief comments. Thank you.
Thank you very much. I really appreciate your words, and I think it's the same for everybody who is here, because you are touching some very important point, and you describe the situation, which is a little bit different from, let's say, Europe or the situation we know from day to day, but it's very important because you have a large population of patients, and the number and the incidence of risk factor is going to increase in the many countries, in particular in sub-Saharan Africa. And so I think that the problem of treatment and the problem of adherence is absolutely most important in that area of the world. So I think that the contribution, your contribution would be crucial for the, let's say, understanding and for the building of these, the final documents for this very important coalition. So now it's time to move to another non-European countries and another very important experience from the world. And I would like to invite Professor Rajeev Gupta to take the seats. And Professor Gupta is actually the president of the Preventive Cardiology and Internal Medicine at the Eternal Heart Care Center and Research Institute, which is affiliated to the Mount Sinai in New York, and is one of the most prominent scientists in the great country of India. So, Professor Gupta, the mic is yours.
Thank you, and good morning, all of you. I represent India, which is the largest country in the world right now. And the largest burden of non-communicable disease, largest burden of coronary artery disease, largest burden of hypertension and diabetes, what you have. So clearly the problem is unique in our country because of the, well, developing health system, as we call it. I call it a fractured health system because we have private sector, which is large, almost catering to 60% of the outpatient care, and about 50% of inpatient care. And we have a government health system, which is small, which is still in the development stage. The second thing is the insurance coverage in India. The private insurance coverage is less than 5%. There are government schemes which have been there in the past, covering about 10% of people. And the new scheme of the government, which is the it's been going on for the last 15 years now, is trying to cover more and more people. Government data say it is covered 50% of population, but the ground truth may be slightly different. And all these schemes are catering to the inpatient care, not to the outpatient care. And that's where the adherence problems comes in, because adherence is more at the level of outpatient care than the inpatient care. And if you do not have proper funding for that, proper vision for adherence promoting outpatient care, you'll end up in trouble. I'll give you a small example. We performed a study known as SPREAD, which was trying to improve adherence using a health worker in 10 hospitals across the country. About 1,000 patients were recruited, randomized. In the placebo group, about 60% of people stopped medication. They stopped catering to the lifestyle adherence changes. On the other hand, at the end of 1 year in the intervention group, which was a community health worker-based intervention, almost 80% stuck to their treatment. But then at our center, we kept on doing the study for another year or so. And at the end of 2 years, what we found that almost 50% of people were not taking their medication, despite having angioplasties and despite having coronary interventions and proper care. So clearly, it's a huge problem. And if you look at the whole data, we don't have data in India how much non-adherence kills people, but there are 45 million deaths from cardiovascular disease annually happening in our country. So clearly, we have a huge number to tackle. So that's the other aspect of it. So what can we do? And I think my previous speakers have told about the social changes, social determinants, improving education. But what unique can India provide to the whole gamut of improving adherence? And I'll just focus on two issues. One is the public health policies. And the public health policies have to be universal and free, primary and secondary health care. I work on secondary health care because outpatient care is important. We need a more socialized and state-funded health services, which is missing right now in our country, and I believe in most parts of the world. Health literacy has to improve. Health literacy means education in the right direction, in the right source of health. For almost 50, 60 years now, our school curriculum, public health messages are directed towards the infectious disease epidemic. I'm not saying that's bad, it's good. We have tried to control it. We have done wonders in the infectious disease control in our country, but now we need to move on to non-communicable diseases also, and that's missing. There are no screening programs for non-communicable diseases in the periphery, in the primary care, and that needs to change. And I think there's a lesson for all of us. There have been new developments in screening programs. There have been wellness centers in the country, about 40,000 of them across the country, but they are still in the process of development. And I believe that once these wellness centers are functioning up and off the ground, they will do wonders as far as the screening and management in the initial phases of the non-communicable disease is concerned. There is a hypertension control initiative by Government of India, which has been adopted by about 10 states of the country. And it focuses on logistics of hypertension blood supply. So the first phase was formulation of a policy. So we are part of the formulation of policy, how to treat hypertension in primary care. The second phase was the logistics supply, that how can we ensure that the medicines are never short of supply at the primary care level. And the preliminary data from the study has shown that, yes, there has been improvement in adherence to treatment. So I think there's one direction which many countries of the similar socioeconomic status can learn. We also need to have the other area, which is the health system change, which I think is important. Community health workers, non-physician health workers, as empowered to treat or to at least check hypertension, and along with the physicians to treat hypertension. And there has to be a legislation empowering these health workers to change or do a bit of quick twiddle of the treatments, and that's happening in our country. Pharmacist-based interventions have worked very well in the high-income countries. There are no studies in India, at least I know of, on the pharmacist-based interventions. Technology-based interventions is the last thing I'm going to talk about, because I think India is the leader in technological development. There have been studies on messaging services on the WhatsApp or on the phones, trying to promote adherence. Most of them are very short-term studies. There are no long-term studies, so we don't know what's going to happen on the long term. And here I think with the interest of Indians, especially in the gaming technology, I mean, most of our people use their cell phones not for learning, they use for playing or watching movies. So I think if you can incorporate some sort of a messaging system within the gaming technology, that can improve adherence. And I can just tell you an example. I use a physical activity monitor, and I keep on telling my patients that, look, I walk 10,000 steps a day, and that's what you should also do. And I use this particular app. And I think hundreds of my patients are now following these things on their apps. So I think it has changed their behavior. So I think if one physician can do in his practice, it could be translated into millions of people following up their physical activity patterns, the food patterns, or their drug patterns, drug intake patterns, using technology. So I think that's where the future lies, and that's what the message is from India to all of the world. Thank you.
Thank you. Thank you very much for your comprehensive point of view. There are some key points that we can to discuss probably later on, but I think the most important is the social involvement. I think it's very important, and just try to, let's say, inform the patient that life is important. They have to protect it. And on the other side, I really enjoy your discussion about the gaming technology, because I know that everybody at every stage is looking at the phone, maybe 10 hours a day, I don't know. I see people that have already changed their posture just to be prone to look at the phone. So I think that this could be a very good idea. So let's move on to the next speaker, which is Professor Mario Neves from the Brazilian Society of Hypertension. Professor Neves has a very long CV, but I think he's director of the medicine, of the Department of Medicine and the Faculty of Medical Sciences in the university, the hypertension clinic in Brazil. So I think, Professor Neves, the mic is yours.
Thank you very much. Good morning, everyone. Actually, I was not expecting to speak in this first part because I was invited for this important meeting 2 weeks ago to replace Professor Andrea from Brazilian Society of Cardiology, where I can talk about something about Brazil, my country. And we have a huge population, more than 200 million people. And the first cause of death is cardiovascular disease, as the other countries. And like 15 years ago, stroke was the main cause of death, but was replaced to coronary artery disease. It means that a little increase in the adherence of drug treatment. So maybe, and we had two important two examples for adherence. First one is the use of seatbelt in the cars, because it was not obligatory a few years ago. And there was a huge campaign from the government, and now it's almost automatic. After entering the car, everyone put the seat belt. So it's a good example. The second example was about smoking. Before this campaign, almost 40% of population was smoking, and now only 10% of Brazilian people smoke. So there was a huge involvement of the government. It's important to improve adherence of our population. Maybe we can stimulate our governments to participate in this issue. We have in Brazil 70% of population depends on the public system. Only 30% is the private or health plans. So we have a huge public health system. It was important in the pandemics, but we need a lot of kinds of improvement. We have trying to improve our primary care, because most of our hypertensive patients, diabetic patients, are ours in this system. But I believe that we have some kind of like stakeholders of this drug adherence. And maybe the doctor's point of view, we need maybe early intervention, maybe in medical schools, because drug adherence is not discussed in our curriculum. So maybe we need to stimulate. And you know, Brazil is the second country that we have more medical schools. We lost only for India. Of course, India has a huge population. But so maybe we need to discuss in our medical schools with our medical professor, because we discuss about hypertension treatment, diabetes treatment, but not about adherence. We of course we have our patients' point of view, so we need more educations, and not only for patients but for their relatives as well. especially for older people, because sometimes we have the cognition issues, so we need the involvement of their relatives. Of course, as I said before, we need the involvement of the government, local and national government, to improve the drug adherence. And like this, the medical societies and the international organizations, so we need to discuss more about drug adherence, otherwise we cannot improve the cardiovascular outcomes. So this is why I remember to speak now, but we can discuss later in the second panel.
Okay, thank you very much. I think that you mentioned that you are replacing someone. I think in this concept of coalition, nobody is replacing anybody. Everybody contribute to the activity of coalition, from the World Health Organization to, let's say, the drug company, the top levels of the drug company. We are all together trying to get a result. So I think your contribution is absolutely important. And I really appreciate the mention about the problem of the medical school. Of course, we have to start by growing up doctors that have the idea that drugs should be taken, not just should be given. We know that we give drugs, we prescribe drugs to our patient, but probably we don't know that the patient has to take it. So we have to change the mentality. And I definitely agree with you that it's a very important step for the future, for the improvement of adherence in the future. And now, last but not least, my friend Michel Bournier. Michel is almost everything, but basically is the honorary professor at Service of Nephrology and Hypertension at the University Hospital in Lausanne. He knows very well the problem of hypertension. He knows very well the problem of adherence. So, Michel, we are waiting for your point of view.
Thank you very much. I think most of the things have been already mentioned, and I can only agree with everything which has been said before. I might just make a few comments on what has been already said. First, in Portugal, you look at the determinant of non-adherence. If you look at a recent review by Cardas, we identified today 471 determinants of non-adherence, which this number just illustrates the complexity of the problems. So, you know, when you want to develop a strategy to improve adherence, you really have to identify the target. And of course, we cannot go for all targets. And I think this is a very important issue. And I mean, we have been listening to all the different issues that come from different countries. And I think there is not one size fits all for the programs of improving adherence. Probably every country has to. Now, Mrs. Khan talked about silence. I think the silence is very important. We talk always about hypertension as a silent killer. I think probably the biggest silent killer is non-adherence to anything. Communicable and non-communicable disease. Because HIV, I mean, the problem is in cardiovascular, we tend not to read the papers in other domains. And in the domain of HIV, they did a lot of things on adherence, a lot, much more than what we do. And they came to something very important strategies, you know, about HIV management and improving adherence, as you mentioned it. But the silence, who is silent? I think everybody is silent. The doctors are silent because they prescribe. They have 5 minutes. They always say we don't have time to talk about it, so they don't talk about it. Now, in our survey, in Europe, in 5 big countries, Spain, Italy, France, Germany, and UK, 60% of the doctors never had any teaching on adherence and how to communicate with patients. It's a huge gap. We know everything about the pharmacology, but we don't know how to talk to patients about these drugs, how to prescribe, how to take it, what happens if you miss a dose, whatever. So I think this is interesting. But we did another survey asking patients what they think. And patients, 40 to 50% of patients don't dare to talk, to say to the doctors, I'm not on not adherence, and I miss frequently doses, because they have so respectful for doctors that they don't want to disturb them, you know. And they don't want to criticize them. They are very respectful, at least in Europe, probably in other countries too. But you know, this may change with the new generation, getting a little bit more aggressive. But but at least the older people, they don't want to disturb. So I think this is a very, I think it's a very, very important issue. So I think maybe one strategy that really would work everywhere is really to talk about adherence, to break the silence, and maybe make adherence the silent disease of the future, of today, at least, in everywhere in the world. Now, of course, all your problems of access to care, access to, I think education is a very important, but we still need to, and I think it's very important what you said, we need to educate doctors. And doctors are, it's not only, non-adherence is not only a problem of patients, it's a problem of all. And at the ESH now, I think we put quite a lot of emphasis on education of doctors. We work also with that tool. But also, one answer that we always receive from doctors is that we don't have time.
Yeah.
Which is true. They don't have time. It's probably in India, I don't know how many patients they see a day. I mean, how can they talk about for 10, 20 minutes about adherence? It's not possible. So my answer is always, if you can't do it, let somebody else do it. And that's so easy. So who else can do it? Partnership with pharmacists, we heard, I mean, you have some. We have a big program, Belen can say here, also in Geneva. But not just, you know, have a partnership like that. What Marie-Paul Schneider did here in Geneva, which I think is really a big success, she managed to force let's say, an educative program, obligatory, for pharmacists and doctors in the same time, in the same room. So instead of being pharmacists here, doctors here, no, we go in the same room and we have a course on adherence together and how to work together. I think this is very, very, we have to put these professions together. And we tried with nurses, it was more difficult. The nurses were very happy to have doctors, but the doctor didn't want to come to the courses because it was not obligatory. You see, if it was a choice. And I think this, we have to change the way we educate people in the future, also in the medical school. And I think this is very, for me, it's a very, very crucial. And of course, the access to care. I mean, the cost, we always talk a lot about the cost, but you see, we did a study with Pascal Beauvais in the Seychelles Islands, where the cost, there is no cost for the drugs. They receive the cost free. But the adherence was very low. So it was not a problem of cost. And we discussed this morning with another lady, I think, when we interviewed her, why is the adherence so low in the Seychelles Islands, especially among men? The answer was, oh, the drugs interfere with the alcohol. So you see, here in this country, the major problem in men was the interactions of drug with alcohol. So they had to choose between the two, and of course they choose alcohol rather than the drugs. So maybe we had to explain and change the things. So I think it's, I mean, these are big challenges to identify the problem. So, and I really thank you for giving all your perspective on adherence. And maybe if we manage, you know, Professor Cardas, who contributed to the WHO first document, you know, in 2003, which was really very important, very crucial, always cited in all papers. We try now with a couple of specialists in Europe and in the US to update this paper and propose what are the important new steps for the future. And well, we hope we'll be able to publish it in a good journal for the month that we're still going around. Thank you.
Thank you very much, Michel. I think that you made a wonderful summary, and I think that even whether the experience seems to be different, the problem of education, the problem of knowledge, the problem of time seems to be pretty important. Try to find out the solution. I was struck by your observation between drugs and alcohol, that the choice, the interferent were the drugs, not the alcohol. It's pretty strange. But anyway, I think that we have closed this first part of the meeting. We are, let's say, 7 minutes later, but we have 2 more speakers when compared to the original program. So if you discount these 2 speakers, we are exactly on time. So I would say that at a loud voice, that exactly on time, I hand over the microphone and the podium to my friend Atul Patak. Thank you very much to everybody.
Thank you, Claudio. As you mentioned, we are a coalition, so no enemies in the coalition, so no problem with timings. I will slightly change maybe the organization of the second panel and straight away ask my panelists to attend the stage. So Mrs. Aiste-Starrett, maybe you can just join the stage. Olivier Laureau, you can join the stage, please. I'll ask the panelists to join the stage at once. Professor Belen Ponte, please. And Dr. Jean-Luc Aisele. I will introduce them, don't worry, but it would be better to have them all together. I think you have to understand that what we are sharing today is a journey. And this journey started a couple of months, or I would say even years ago, but was crystallized a couple of months ago in Brussels with a wonderful initiative bringing up the concept of patient adherence as something which has been voted twice by a member of parliament of the European Parliament. So a really important step, because you need to be supported by policymakers and also finally actors who are not directly involved in patient care to help the concept to move forward. And at the end of this panel, I will show you the second part of our journey, which is the release of the manifesto, which is summarizing the call of action we are going through this morning. What I really wanted to share also with you is that we are all talking about the big elephant in the room, no offense. The big elephant in the room is the patient. And so, without further delay, because we are all talking about the patient, but we have not heard the voice of the patient. And so it's my privilege to introduce Ms. Aiste-Starrett, who is, I think, a leader in terms of patient voice. She's been very active as a patient herself, but also as the voice of a lot of patients suffering from heart failure. And she's been through a wonderful journey, sharing her experience and her thoughts about this situation. And I'll be happy to hear what are your thoughts about this concept of patient adherence. How can we improve things? And finally, also, what are your expectations? Because we have very good ideas. We are talking about patient adherence for years. And I think it's important to listen to the patient's voice. So the floor is yours. Thank you.
Thank you very much. It's a pleasure to be here and represent patients. I'm a survivor myself, and I've been living with a transplanted heart for 3 years. So I'm very happy to talk on this topic because adherence is very close to me. A funny side, I was very adherent all the time, and I still am extremely adherent, but maybe that's why I'm here and I'm feeling well, and I have everything in control, and I'm leading a really great life. So talking about the issues, there are a lot of issues. We already heard quite a lot in terms of the first panel, the major challenges on the policies in the countries, the access to care, a lot of different challenges. But in terms of the patient community, what we are facing, there are 2 major things that I would really like to highlight today. And we already heard from the previous what was mentioned, doctors do not have time, and we do understand that. But we have to understand that adherence is a shared whole and a shared responsibility, and that is between the providers and the patients, as well the caregivers and the family members. We as well heard that, you know, in the first panel, a story that the family members were really not knowing of what is happening with the patient. So I think the priority here should be as well how we can make sure that we have a family members, the caregivers, always with the patient during the visit. So to make sure there's another person who can really make sure that they receive all the information. As a patient, when you go into the visit with a very short time and you don't, like, everything is going so quickly during the consultation, you cannot really take all the information. And as well, it's support, to have a support there, it's really, really important. So that's the first thing. The second thing, how we can make sure we collaborate. And I know the time is difficult during the consultations, but the communication is the key here. So how the providers can really communicate well with the patients, with the caregivers, and agree and make the combined decisions on the treatment, on the goals, on objectives, how to select the treatment and the management, and even the medication taken behavior, right? So the conversation has to be there in one way or another, and by including what has been said as well, and I completely agree, we need to involve everybody else. What about the nurses? What about the pharmacists? What about the patient organizations, clinical societies? They are there. We have the tools. Yes, we need the support, and I represent the patient organization, national and global. So we do need support. We do need those collaborations, the information on the medications, but we have to work together because we are able to actually support the information for the patients. We are able to even assess the patient needs, which is really helpful. Another thing that I wanted to say is, of course, which has been mentioned, the health literacy. So we do know there is a lack of knowledge and behavioral changes that needs to happen as well. And we have to focus not only on the patients, but I think we have to step a little bit like back and think about the general society. So how we talk, we do not talk, and we have to start talking about that. And as well, we have to make sure that the educational materials are available for everyone. We have a treatment, we have a medication, but one medication cannot fit all. So we have to make sure that as well, that the treatments are more tailored to the patient needs. And in the sense that the communication that goes between the provider and the patient agreeing on that is very important. Coming back a little bit, I made a step back. Coming back to the health literacy, there's an approach as well of how we can apply the teach back approach. So again, understanding that we do not have a lot of time during the consultations, but when the information is provided for the patients, we can ask them to repeat that information in their own words. Do they really understand what the medication is about? Why are they taking it? What are the risks potential as well of non-adhering to medication? And as well, another thing that I would really like to highlight is the regulation for the medication labeling. So we know the patients really rely on the medication information and leaflets as well. So the information that is provided there is not really understandable for the patient. So how we can make sure that those labels and medication information is provided in a lay language so the general society can really understand those things. So from my side, working together, communication is a key goal here. How do we make sure that we increase the health literacy? And even though we understand we do not have a lot of time during the consultations, but we can do that by involving others as well to support us and to make sure, you know, the effective communication does not really take a lot of time. So maybe we can learn that from that as well. Thank you.
Thank you very much. I think you deserve an applause. Thanks for sharing your experience, and as you understand, this panel is really about a call of action involving multiple stakeholders, and I finally like the concept you shared, which is going beyond the doctor and try to find the help of other healthcare provider, going beyond the patient and try to find the help of other caregiver, and go beyond the classical approach of delivering drugs, maybe the involvement of drug labeling, and maybe also using the concept of teaching and getting back information. So thanks for your thoughts, and thanks for sharing your time and your experience. And so I'm really pleased because I have a panel where I only have CEO. So I have CEO of the patient. Now we'll have the CEO of Servier, who is also supporting us in the development of this very nice morning. And well, the voice of drug company, the voice of the pharma, I think you are a very important actor in the field. You are delivering what we are talking about, which is prescribing a drug. So what are your thoughts and your view about this concept of patient adherence, and how does a CEO of a big pharma stand and support this concept?
If I may, I will not begin my speech by speaking about the CEO responsibility or the pharma responsibility, but as a father, when you have to push your son to adhere to his treatment daily when he's a teenager, he doesn't want to take the drug daily. When he is on a motorbicycle, who is not taking the drug which is necessary for his treatment, anticoagulant, then you are afraid. So as a father, I can first testimony that it is very difficult, very close. You say use the family, but it's very difficult to push your family to adhere to the treatment, especially when he is 12 years old, 20 or after. That's father. So yes, the family is very important. Second, as a CEO, and especially as a CEO of a company which is not comparable to the other because we are governed by a foundation. That is to say, no shareholder, no money for shareholder. It is our social responsibility to be involved in adherence. It is our social responsibility. Yes, we must be involved in research, in development, in access to the market, in quality production, but we must also be involved deeply as social responsibility in the adherence to treatment through different manners, tools, and so. Just come back to some figures, because that's important. Today, in Europe, more than 200,000 deaths because of non-adherence to treatment per year. That's too much. In US, it's 125,000 deaths per year for non-adherence to treatment. And through your publication, Professor, recently you evaluate with some other author that the cost of non-adherence to treatment in Europe, it's 4.6% of the total cost of health expenditure. Imagine what it represents. It represents almost 270 billions of euro worldwide. Can we stay in this situation with no reaction, with no communication, and through a meeting that we have here today? It is the way to limit this amount and to conduct this amount to be lower and lower and lower. That's so important. We make a first step when we were in Brussels, most of us in the European Parliament. It is a first step. And thank you again for those who were with us. We succeed, but it is a first step. We succeed, as you said a few minutes ago. In the non-communicable disease report, it has been said that adherence is key. It has been voted. Second, in the package pharma law, which has been voted in April last, it has been said that adherence is key. For me, that's just a first step. We must be involved more and more. And today, because we are here through the manifesto, it will be a second step. And thank you again. And I congratulate all of you and all the peers who are with us. And we like to have more pharma company with us to be deeply involved in this, I would say, in this main issue worldwide. It is not only death, as I said, it is also quality of life for those who are not so clear with the adherence of treatment. I was in Morocco a few weeks ago. I met somebody in the hotel, a woman. She was not so far working for the kitchen. I just speak with the morning breakfast. I speak with her. She was not following her treatment. She said, I stop. I continue. I stop. I said, no, please. It's heart failure you have. Please follow your treatment. Find a solution. We can help you. we can help you as pharma company. Not only we have tools, IT tools, which are very good today. You referred to single pill combination a few minutes ago. We are deeply involved in single pill combination. Okay, it's huge development, it's quality production, and so we need to have more and more single pill combination, 2, 3, and 4 if possible. It is for better adherence to treatment. Be sure that our company will be deeply involved. I will support the manifesto, of course, but I will support inside my company all the 22,000 people working worldwide for Servier to support the manifesto. That is to say, not to speak about drugs, but the environment, the adherence. Help the family to conduct, as you say, the practitioner, nurses, pharmacists, it is key. Yes, and I can say sincerely that I am proud to support this manifesto as a pharma company, as a foundation. Thank you.
Thank you. Thank you very much, Olivier Leroux, and for sharing your vision as a father. I think it's important when you ask somebody to introduce himself, we always start, I'm a cardiologist, I'm the CEO. You started, I'm a father, and I think it's really, it's a very important aspect in terms of communication, and I think it's also the nice way to promote a cause. And thanks for sharing your vision and the support of your company and the way you see the future involvement of your company, the present involvement and the future involvement of the company. So, voice of the patient, voice of a big pharma company and a father. And so we'll move maybe to a wife, a mother, but also Professor Belenpont is the head of department of the hypertension unit in Geneva. She's our local host. And she's also been an active member of the Swiss Hypertension Society, actively involved, as Michel mentioned, in some very specific actions. So maybe the voice of academic practitioner, the voice of somebody who's working in a university hospital, maybe share with us your view or some examples you've been set up in your department to support patient adherence. Thank you very much.
Thank you very much to all of you for the nice invitation, and I'm quite proud to be here surrounded by such amazing speakers in this very important topic that we don't heard so much about it, and I think listening, speaking about it is already very important to recognize that this is a problem. Many points have already been mentioned by the previous speakers. We have to educate, we have to monitor, we have, of course, to know the treatment, and then to make sure that the patient is taking the treatment. And I think in the room we all have in view these schematic from the Lancet a few years ago, where you have, okay, maybe 50% know they have hypertension, and from those, only half of them will have medication, and maybe 1/3 of them only will actually take this medication. And I think that this message is very important. When I saw the numbers of the global health system last year, I was quite proud to be in Switzerland, looking, okay, the numbers of hypertension prevalence are looking good compared to the other countries, but we're still facing the problems of not treated hypertension and not taking medication hypertension. And how is it possible in a system like Switzerland, wealthy with a very good health public system, that we're still facing the fact that 20–30% of hypertensive people are not taking their medication? We can't say that it's just because we have a lot of foreign people, maybe it's education. It's certainly not only that. And I think, as Michel said before, it's really important to identify why people are not taking the medication. So one point is, okay, to educate the doctor, probably to educate also first the students in medical school, not only about physiopathology, about consequences, but about the importance of speaking with patient. And here in Switzerland, we have like a program trying to push students to go to the general practitioner view. And I think targeting the general practitioner is very important, because people first don't go to the specialist. They first go to their GPs in who they have trust and who maybe doesn't have so much time to speak about them, but who, by seeing them regularly, will at some point be able to touch them, to speak with them, because patients have trust in them. And we really have probably to push not only the insurance company, but also the global health system policies in our countries to implement some time for actually in the consultation, to allow the general practitioner to take some time for speaking about just prevention. Maybe just say, okay, 5 minutes of the consultation could be dealing just with general prevention, hypertension, cardiovascular risk factors. All of those factors are silent killers, chronic kidney disease also, and people don't understand why they have to take medication if they don't feel the need of, because they feel healthy. Every patient say, but I don't understand, I feel well. Why should I take medication? And of course, educating the patient is very important. And I must say that, for example, in Geneva, we have the luck to have people really involved in the education policy of the patients and developing programs to educate people. It has been done with chronic kidney disease, but now they are developing tools to make educational patient program targeting hypertension with some labeling, like figures where they show what the consequences can be. And it's a work that has been done with nurses, actually, with doctors. So both are involved, and it's very important because nurses have other words than we have. We are being very scientific sometimes, and people, maybe patients, don't understand always our words. And pharmacists are also very important because they are also developing all adherence control program. We have a Pharma 24 in Geneva with a very good pharmacist taking care of this program and also involving us in maybe sending the patient to adherence system, which is quite difficult because when you tell a patient, okay, I suggest to you that maybe you go to this adherence program. Say, but I'm taking the drug. So it's quite impressive, I must say, as a doctor. I'm sure all my patients are taking their drugs, but still 20-30% of patients are not taking any drugs. So are we bad doctors? Do we have the wrong patients? Or it's just the fault of my colleagues? No, all my patients are taking my drugs, but they're not taking the ones of my colleagues. So speaking with the patient is very important, but also speaking with the nurses, speaking with the pharmacist. And we have, I must say, for 1 or 2 years now, facing the problem, even in Switzerland, of medication shortage, in some medication shortage. And I must say I was quite shocked about that. How is it possible that in Switzerland we heard about this medication shortage in some important drugs? And for that, the work with pharmacists was very important because they are the first to know actually that the medication is out of shortage. I was always called by the patients telling me, okay, the pharmacy tells me that there is no more drug. How is that possible that we doctors are not aware of that? It's amazing that we have to know that by the patient or even by the pharmacist, and that we might have to find another solution just with a quick solution, with a quick discussion. And this discussion must be done with the pharmacist and also with actually the companies who provides the drug and who probably should be the first to tell us, okay, we are facing a problem of shortage. Why and what can be done with that? And it can be a problem with the actually combination pills, because what are you going to do when your combination pill is shorted? You tell the patient, okay, now you take 3 pills instead of 1. He's not going to take them. So I think that we are pointing out, thanks to this panel, very important points. As national societies, there are some things that we can do, and probably in Switzerland, we would have to do something better, like really go to the health system politically involved. I'm quite impressed by Portugal, who managed to decrease actually the salt in their food, because we know it's a national gift, the salt in Portugal. So it's quite impressive to see how they were able to actually convince the politicians to make it actually mandatory. We were not able to do that in Switzerland. It was impossible. Okay, we have the cheese, which is also a national gift, but I mean, how can you not reduce the salt in bread? We're able to reduce it a little bit, but it was like, okay, no, it's a question of money. We can't reduce it more. And money in health, in wealthy health system is already a problem. In Switzerland, we are facing the fact that we have not just one insurance system, we have many insurance companies, and actually even if all people can get an insurance and can be paid by this insurance, we are facing the fact that not insurance don't want to reimburse all the treatments, which is also a problem because patients don't have the choice to have insurance. It's mandatory. And this is also a problem that we're facing in Switzerland, how to get through the insurance companies to convince them that actually reimburse the doctor for the time he's spending with the patient just speaking and just talking to him and try to convince him to take the medication, but also convincing these companies that it's important to reimburse these medication, that it's meant to be maybe prevention in some time in some patients, but is also already a treatment for some complication. So I think that those are all the problems that we are facing here in Switzerland.
Have you heard about the BPP, the Belén Ponte program? I think she has been able to summarize a lot of call for actions. I think a lot of ideas we've been talking and sharing have been summarized, giving us also your insight about the vision in your hospital, in your country, but I think which are global actions and things you can all understand and find as valuable in other parts of the world. So thanks for sharing your time and your experience. And you deserve applause. Sorry, I shortened the applause because of the... Thank you very much. And so last but not least, Jean-Luc Aizelet, my last CEO of the World Heart Federation, and maybe also a special thanks to the World Heart Federation for organizing and supporting us and hosting us in this very nice city of Geneva and allowing us to be all together. Thanks to your help, your support, and I know that what we see is not necessarily what you have done, and I know you've been working hard. But we also like to listen to your voice, the voice of the World Heart Federation, and how you as a medical association, as an association which is involved in supporting education, patient and physician throughout the world, could help and support the concept of patient adherence. Jean-Luc?
Thank you very much, and thank you for all of you for joining us today. I'm living not very far from Geneva, so let me start just with a personal story. I'm on statin since many years, and my GP never asked me if I was taking my treatment. I never had the question, okay? And last year I retired, so I had to change. I got a new woman, and the first question she asked me, do you take your treatment every day? And of course I said yes. But if she would have asked me last month, how many times did you miss it? Response would be 1, 2, 3 times, and then you have discussions. And to me personally, it illustrates the complexity of this adherence question, which is not in a educated country, excellent healthcare system with rather aware person. It's not easy to address this question of adherence because it's multi-complex and it's multi-factors. Now, as World Heart Federation, what can we do to change things and improve this adherence to treatment and cardiovascular health globally? So, as you might know, we're a federation of national societies, national cardiac societies, foundations, over 220 members in 110 countries, and our main strength in this convening power that you have seen today, where we can bring Professor Ogola from Africa, Rabji Gandhi from India, Brazil, Switzerland even. And this is really our strength, and we work at two levels. One is global with WHO, because we are an official relationship with WHO. It means we can attend the Health Assembly this week, we can make proposition comments, and that's global advocacy, I would say. And the second is implementation at the country level with our members. Everything we do with our members, through our members. So how does it work? I'll start maybe with one example which is more technical, and it's advocacy towards WHO. As you know, WHO had this essential medicine list, which is a kind of Bible for many countries. WHO, some years ago, developed new guidelines for hypertension, which recommended combination therapies. And WHF has been working very hard to get this combination therapy on the essential list of medicines. And it took a few years to get it. Now it's there. And as Professor Ogola mentioned, it's really useful at the country level. 2 years ago, we managed to get fixed those combinations on this list, but it took us 6 years. 6 years of work. There might be some good reason that maybe evidence were missing, but it's a huge work of advocacy that WHF is doing here in Geneva, just to get this kind of policies and regulations at the global level. So that's the first thing. The second thing is, if we speak about implementation, what could we do at the country level to help our members to improve cardiovascular health? So we have two initiatives. One we call roadmaps, and it's a document which take hypertension. Here are the guidelines. What are the main roadblocks globally why the guidelines are not implemented? And what could be some of the solutions that could be used to improve the situation? So that's a document. It's a framework for discussion. And the roundtables are events organized at the national level. And I'll take the case of one we did 5 years ago in Kenya on hypertension, where because of the convening power of WHF, we can bring Minister of Health, scientific societies, cardiologists, nurses, media, patients, industry. And let's discuss during one day why is hypertension so poorly managed and treated in Kenya. And I think Professor Ogola gave us some ideas already. But one of the interesting points which came out of the discussion, it was not so much the cost or availability, it was the fact that only doctors could diagnose and prescribe hypertension. And nurses, community health workers were not allowed at the time. So again, working with the Cardiac Society, we managed to change the national guidelines so that now nurses and community health workers can diagnose and prescribe. And not only this, but also help to train 2,000 health workers in Kenya, which now can work on this. And of course, when we come back to adherence, we know that nurses are much more efficient and community health workers are much more efficient than cardiologists, doctors for this. So that's a kind of, I would say, practical work and practical implementation we do to improve the cardiovascular health. Maybe to conclude, so WHF is very much on prevention, awareness. Prevention starts, as we know, by socioeconomic determinants of health, behavior, a global perspective. It includes also climate change, air pollution, these kind of ideas. This is also about early diagnosis and management of disease. And if we think about these three words we've been using in terms of treatment, which is access, availability, and affordability, the 3 A's, it's probably time to consider that there's a 4A that we need to include in our reflection, which is adherence. And I'll thank you.
So Claudio, teamwork work. I'm just 2 minutes late. So we are doing a great job together. I think I would like first to thank my panel, and because I think you did a wonderful job and sharing with us your visions and adding value to what we've learned from a global level, macroeconomy, microeconomy, what you can do at the level of country, what can do at the level of individual experience. So maybe we could use now the remaining minutes to share and maybe to do the global panel, which is bringing the two panels together, and maybe ask the audience to use the mic, which will go around. And if you have questions or you want to get some further information, be happy to ask our panelists to answer to your questions. Any question from the floor? Any remark? Yeah, Michel, please.
I just wanted to make a comment to your last speaker. Actually, you're very, you should be very happy to be treated by a woman, because now there are data just published recently showing that in cardiology, the risk of mortality is decreased by almost 10% if you are treated by a woman doctor compared to a man doctor.
In surgery as well.
Yeah, in surgery as well. In surgery as well.
It's the same if the doctor is also your wife. We have to make a trial on that.
Any comments or questions? Yes, please. Can you help me with the mic? Yes, thank you very much.
Hello, thank you very much. So it was very interesting to hear a lot of the discussion on the panel, and I was particularly interested around some of the interventions made around the use of fixed dose combinations for hypertension, but also wanted to slightly off the hypertension point, but there's the World Health Federation, of course, played also a very important role in including in the WHO essential medicines list the fixed dose combinations for primary and secondary prevention of stroke. And I was interested in hearing from the panel if there are thoughts around the role that those combinations could play, but also what are the kind of challenges that are there on the ground to actually using them. I was hearing with much interest hearing the words from our friend from Kenya here who was talking about the important role of these combinations in hypertension. I was wondering whether he had similar appreciation or similar stories around the polypills, the so-called polypills for. So thank you very much for that.
Anyone wants to take the lead to answer? Please, maybe you could give us your thoughts.
Well, I thought Jean-Luc was going to talk about this, but what is happening is Jean-Luc has talked about the roadmaps in the WHF. So one of the roadmaps that is being developed right now, which I have the privilege of being part of, is one on the polypill. We are actually sort of debating which terminology to use, FDC or polypill, so that we extend this paradigm from combination therapy for a single condition into something that tackles multiple risk factors which can be used in primary or secondary prevention. So those are the issues that we're discussing. What are the barriers? What are the issues in terms of implementation? A typical example, for example, is barriers, one, in just the availability of the polypills globally, and how many companies manufacture them, so that has got impacts on cost. There's the question of acceptance within healthcare systems and therefore reimbursement. There's the issue that where there are already individual compounds available generically, then the combination tends to be more expensive, so how do you go around that? So those are the issues that we're trying to get into this document, which we are hoping will probably be ready by the time of the ESC in late August.
If I may, because we are deeply involved in SPC and single pill combination, as you say, development is very important, and regulation is increasing a lot. So today, bioequivalence is necessary. Certain countries are going to ask for phase 3. Then the cost could be very high. And regarding that, for market access, the price is very low for single pill combination, because today, in most of the SPC, the price is just the addition of the generic cost. So how to have the payback of the investment we made in development in the price? Second, as has been said, yes, there are shortage, but you know that shortage is multifactorial, coming very often from the API, coming from Asia, very far away. So today, it's not so easy to have every day no shortage, and we work a lot for that, especially for our SPC. Be sure we are deeply involved in that. But second, if we look at the 10 years to come, what will be the evolution of the regulation concerning SPC in terms of phase 3. It could limit the development of phase 3. And what will be the price according to the countries, of course, but because of the savings in adherence program with SPC, we must have a global approach and not only addition of the cost of the generic drugs which are in SPC. Look at the savings which are made with SPC. It's the figure that I described this morning. And I thank you again for your federation, World Heart Federation, because you understand clearly that we must have a long-term view, working not only with practitioners as you are, but the industrial, the patients as you are, and all the community people. Thank you for that, because it's so rare to have such a federation with everybody around the table working for the future. Thank you for that.
Yeah, just one comment to the question. We have been involved in the polypill studies for many years now. The future, I think, is the combination therapies to prevent and treat CKM, cardiac kidney metabolic disorders continuum. And I think that's where the future is going. India is a pharmacy to the world. We have lots of single pill combinations, including the polypill types of combinations. So that's one. And there is a recent meta-analysis clearly showing that polypill is working not because of the individual pharmacological constituents, but also by promoting adherence. So I think adherence is a crucial aspect in promotion of better health due to the polypill concept. But I think I'll move away from that to include other drugs which can prevent kidney disease, which can prevent diabetes in this combination.
Yeah, maybe just a couple of comments. I think the concept of polypill has to be looked after at an individual base and at a global way. So I think from a population perspective, and initially the first, the seminal paper where methodology paper where the concept was modelized and the expectation was that polypill could reduce the burden of cardiovascular diseases in a wide population. So I think the global burden, polypill is a good answer to the global burden. At a local level, the history of a patient would sometimes require to stop the polypill, restart, change the polypill. So you need polypills, but maybe different type of polypills. For a diabetic patient, for a patient with CKD, for a patient with hypertension. But in the essential list, for example, the combination, the single pill combination is already answering partly to your question, because they are combining a lipid-lowering agent to a blood pressure-lowering agent. So they are addressing multiple risk factors in a single pill. So it's already a way to answer to the question of the global burden. Second, I think that the concept of polypill is something which has to be looked after according to local or global prevalence of diseases. Probably that the polypill in India will not be the same as the one in Africa, will not be the same in South Africa or in South America. There are common diseases, and then there are local issues, temperature, other diseases, comorbidities, other drugs, interaction with other drugs. So I think it's important to have all these things in mind, but having a single pill combination in the list of in the essential list of the World Health Organization is a very important step, as you mentioned, Jean-Luc, because it's showing that there is a changing in the paradigm of treating the patient. It's not just about treating a disease, it's about treating a patient in a more holistic approach. Any other question? Yes, please, Claudio.
No, just a note. I think I really appreciate Dr. Leroux in his intervention, really recent one, that the company has to pay a lot of money to develop fixed dose, a single pill combination. I think when we talk about polypill, the concept is very attractive. If you want to manage, of course, adherence is much better. Take one single drug in the morning or whatever, whenever you want, and that's okay. But the problem is try to develop a good polypill, and the good polypill depends on the drugs. If you take drugs because they are off patent and you put together because they belong to a family, statins and a beta blocker and ACE inhibitor, it doesn't mean that it works as a polypill. The polypill should be made by drug that have a compatible pharmacokinetic profile. They distribute over 24 hours. For example, the choice of statins can be critical because not all the statins works for 24 hours. So if you take in the morning or in the evening, probably something changed. So I think that polypill is important. I think a good research beyond polypill is important as well. And I totally share the position of Dr. Leroux that when you develop a good polypill, you cannot go to the, let's say, health authority and try, and what you get back is just the sum, arithmetic sum of the price of the different drugs. And in Italy, probably they also will reduce.
Yeah.
By about, I think the rules are to reduce about 10% of the price of the generic drugs which are in the polypill. Because there is a lot of research, I think, also in trying to look which one are the right drugs and the right combination.
I think it's an important point, the level of evidence expected or needed. And we have to come maybe with new methodology, real-world evidence, gathering maybe data in a different way. And you are absolutely right, polypill is not just the sum of drugs available, but there should be a real R&D behind the concept, chemically, from a pharmacodynamic, pharmacokinetic, but also from a strategic point of view. So really important. I think we shouldn't simplify the concept of polypill to just adding chemical compounds, but there is a need of evidence and science.
If I can add just a short word, I'm sorry, Michel. You have also considered the differences in terms of probability of side effects between the drug and the polypill. For example, aspirin is a drug that can give a remarkable number of side effects, much more than the other drug. So if you have aspirin inside, you have to dismantle all the concept of the polypill and try to translate into 5 different drugs, or 3 plus 2, which is something that is pretty much far from any adherence.
Right. I think maybe the last quick comment, Michel, and then I will close the session.
No, just before, I really appreciate your comments, because I think creating the good polypill is difficult because you have the side effects, what you stop, what you change, how you increase the dose and things. But really the concept of the polypill is really very different from the single pill combination. Because if you take the Gauss distribution of hypertension, with a single pill, we take the high-risk patients that we would like to move left. With the polypill, we would like to have the entire distribution curve move to the left, which is totally different. And also because of that, if you want to investigate the polypill, we probably have to change the way we assess the results. And for that, probably we need to develop what some countries have, which are the national database on mortality, on morbidity, and follow large populations for years. And you know, in Scandinavia, they're very strong on that. In Switzerland, we are very poor. And you know, so every country has to adapt. And only with this kind of new tools, not a randomized controlled trial, I think this is not feasible. To demonstrate the polypill, you need another statistical approach.
Thank you, Michel. So to conclude, I think no words, just an image. The image of the manifesto, which is going to summarize what we have been through this morning. So I'm happy to show you the first page and the title of this manifesto. And it's also the occasion to thank all the panelists. Again, the World Heart Federation for their support, Servier for supporting the action, and all the people who traveled so far and who were there on time, and also you, the audience, for joining this wonderful meeting. So thank you to all of you, and have a nice day.